There you go. So let me go ahead and do the introduction. Welcome to the research seminar series that the Institute for Neuro-Immune Medicine sponsors every month. As you all know, but I'll repeat it again, that we do this in large part to develop collaborations and have a better understanding of what each other are doing so that we can work together and help each other be more successful and make all those great connections. It's for that reason that this isn't a 1 hour seminar, it's an hour and a half. So generally speaking, people talk for a usual amount of time, 45 minutes or so altogether. If you run over, it's not that big a deal because we got time. But the last half hour is really meant to foster communication and collaboration, and we use it for that. So there you go. So I'm going to introduce our two speakers. I'll do them both at once because you guys are going to tag team, right? Tag team. So this is really cool because I'm sure you understand that one of the focuses of this university is to develop centers of excellence around the theme of neuroscience. There's multiple themes, but neuroscience is one of the selected areas of excellence. And to that end, they recruited Dr. Locatelli's group. Has it been a year? 2? I give up. Time is blurring. 2 years. 2 years. So, and they've been an amazing contribution to the scientific discourse and clinical care here at the university. So I'm so excited you guys decided to join us for our seminar and be our featured speakers. So we'll start with Dr. Lauren Tabor Gray. Dr. Gray is the director of the NSU Health Kathy A. Hussman ALS Center and is an assistant professor at NSU's College of Allopathic Medicine. She's a clinical scientist and a speech language pathologist. The mission of her current research is to develop efficacious treatment regimens to improve cough function and airway clearance in individuals with ALS in an effort to maintain respiratory function, oral intake, and improve the quality of life. Her research is funded by the Department of Defense, the ALS Association Trials Capacity and Seed Grants Program, and the President's Faculty Research Development Grant. She is also Dr. Locatelli's secret weapon. I know this. Amazing amount of work that you accomplish. Dr. Eduardo Locatelli is the head of this illustrious team, is the medical director of the NSU Health David and Kathy Hussman Neuroscience Institute. That sounds backwards. Dr. Locatelli is also director of the NSU at the NSU Kiran C. Patel Colleges of Allopathic and Osteopathic Medicine. And Dr. Locatelli holds the title of the David and Kathy Hussman Endowed Chair for the Neurosciences. He has been a neurologist for over 25 years. His mission is to provide the best quality care to every patient and subsequent partner. His mission also includes working collaboratively to find cures to progressive neurodegenerative diseases such as ALS. He created and led multidisciplinary teams, merge clinical work with clinical research using real-time data collection and tools to measure progress for personalized medicine. That's just a very little bit that you could say about Eduardo, because he's definitely holding the university to a high bar, which I appreciate as we develop centers of excellence around the neurosciences here at the university. So no further chat by me. Welcome and take it away. You want to hold this thing or use that thing? Sort of a self-serve.
Does it work? Well, first of all, I want to thank Nancy because she called me Eduardo, and I think that's part of the friendship we developed there. It's fantastic. She's been nothing but nice to all of us, and I really want to thank you publicly because I think more than anything, and is that we become friends and we've been helping each other, and I hope to give more to her because she already gave it so much more than I have given to her. But hopefully, yeah. So those conversations will occur and we'll get to go. The second is I'm very happy to be here at Nova. I do know that we all have conversations on the hallways and with frustrations, but and we have no shortage of complaints, but at the same time we balance with a lot of achievements we've done. We've been here for 2 years and we have gained a lot of things. And I hope with this presentation we can, increase the collaboration and find common themes and try to help each other in so many ways. Without going too much in philosophy, I want to tell you a little bit of what we're really doing, because initially, and we have a neuroscience institute and we have seen a number of different disorders, but as we develop now, we're trying to focus particularly in the next 12 to 24 months, as we trying to figure out how to go into other disorders, we're going to focus a little bit on ALS. And ALS, not that one, not this one, is it this one? Maybe. All right, let's move to the next one and maybe enter. So what is ALS? And I think something that we're going to find in common in this conversation is there's features that we have here, and we call it Lou Gehrig's disease or amyotrophic lateral sclerosis. But the truth is that ALS is more of a syndrome than it is a disease. There's many diseases inside, and you're probably now talking about, chronic fatigue syndrome, long COVID, ME, and maybe part of something, but maybe different inside. And ALS is sort of the same thing, and I'll show you more things about that, because we're moving into an era in which we're going to try to further define what are we dealing with and trying to have a population that we can study and is more homogeneous and give us better results. In terms of the frequency, that number of 5 can be 2, can be 4, can be different. But there's 2 things about that. If you study in something I'm interested in, which is the prevalence and the incidence in the world, as we're trying to expand to other countries, it does change. It depends who's counting, and it depends who's not counting. But by the room, who knows someone that in a family or someplace, somebody has had ALS? 1, 2, 3, 4, 5. So usually there is a number of people that, okay, it's somebody in my family, or I know somebody that's somebody. So it's a rare disorder, but actually it's not so rare. When you start looking into the amount of people in the area, you can count, a few hundred in the area. But one of the things we're doing is with telemedicine and reaching out, particularly if you have treatments that other people don't have, all of a sudden your limits go away, because we have, from many different places, including Europe, we have all North America, Central America, South America, and they're coming from many areas in Florida. So what is that we have in the area? Well, it really doesn't matter, because they're coming from different places. But it is a common disorder, even though it's categorized as a rare disorder. The second is, what is the cause? And we're going to talk more about this, because there's commonalities in the other neurodegenerative diseases like Alzheimer's or Parkinson's. I know you guys are very interested in that, or ALS. But when you look at, we're beginning to have 10 and maybe a little bit higher specific genes, which are the cause. And for us, this is very important, because we already have now one gene, SOD1, that has a specific treatment, FDA approved, that has very good information on it. But then is when you begin to say, okay, now I know this is a genetic disease. So you know the gene, you know the signs of the symptoms. So it really becomes a unified cohort in which you can actually address the treatment with something a lot more specific than trying to treat everybody. And then you realize that they're different underneath. But the problem is, it is a bad disorder. It causes weakness and more weakness, and then you can walk, or you cannot move, and you cannot eat, and you cannot breathe, and it gets difficult. So our job is to have this clinic that will address these points from head to toe and give them quality of life, given the care they need. So it is, and then 3 to 5 years, my feeling is this number, which is still the most popular in all the papers that we see, but with some of the new treatments, we hope that and some of the improvement in the multidisciplinary clinics, I think this number is a little bit more, it's a little bit better than 3 to 5. Some of the genetic disorders are really 1.5, from diagnosis, they have a year or two. It goes very quickly. We do have a lot of patients that pass the 6-year mark, so it can be that much. So, but it is really a condition that we have now a monthly call to the people that died the month before. So we wait a couple of months, and then after that, we call the families and see how they're doing, because we lose patients all the time. So this is what we're doing with that. Now, what are the most important symptoms? Really is weakness, but it's a disorder. It's not a disorder of muscles. It's a disorder of brain cells. And the specific brain cells called neurons, neurons of movement, or motor neurons. We have one up in the head in the primary cortex, and we call that the upper motor neuron. Then we have the lower motor neuron, which begins in the brainstem for all the cranial nerves, and then the spinal cord that goes to arms, legs, and respiratory muscles. And they have different features. The upper motor neuron, usually the weakness is more of a slow movement. It's a tight, kind of a spastic, slow and tight. Reflexes go up, and abnormal pathological reflexes may come, like the Babinski or snout or other things. The gag reflex can be very increased. You can have a hyperactivity in emotions, so you can cry for little things or laugh for things that are not so funny. Kind of a pseudobulbar affect, we call that. But, and then the lower motor neuron, really what happens is wasted of muscles of atrophy. And when that happens, they start twitching. We call that fasciculations when we see them. And then atrophy, and the reflexes go away. And you can see the patients are losing weight, lose its muscle, and definitely they get weak. And the tone is very relaxed because there's no muscle there. And for the diagnosis, which is really important, is to have a mixture of the two. You usually upper and lower in the same area is really brings the issue, okay, how can have both? So it's to locate that. If it's a stroke, it has to be upper motor neuron. If it's a disc, it's got to be lower motor neuron. But if you have both, it's very rare you're going to have both conditions in the same person, particularly it's affecting the tongue or the paraspinal muscles, which usually don't have a disc herniation, or very unusual to have isolated tongue when none of the other cranials are affected. And the paraspinal region, the disc herniations are very, very rare. And up to today, we don't have any cure. We can say potentially the SOD1 treatment medication is called Tofersen, brand name Palsary, just recently approved. The trial really show good benefits clinically, particularly as it prolongs, but also recently reports those patients that receive the intrathecal infusion of Tofersen when given within the first year, there was actually reversal of the weakness. So if there's a family member that has the gene and you follow them and all of a sudden they're getting a little weak and you begin the infusions, it's like you're going to reverse that weakness and keep it, stable. I don't know, it's not a cure, but it looks pretty good. So if you hold it at the moment, we look at the moment that we're going to change that gene and just really cure it. But for the moment, you can give an antisense oligonucleotide, which is blocking one of the copies of the RNA and trying to diminish the production of that protein and decrease the hallmark of neurodegeneration, which is the neurofilament. So decreasing the SOD1 protein and decreasing the neurofilament, it shows that it's engagement on the target and is producing the expected results, and clinically they reverse. If you give them within the year to 3 years, you sort of keep it at bay. After that, usually they keep progressing, but it's a very good treatment for at least one of them. So, but for the most, this statement is very true. We don't have a cure. And what we're doing here is trying to establish protocols that are trying to slow it down. And I want to tell you a little bit more about those. This is just to show the same thing. Sometimes this is why it's a syndrome. Sometimes it's in the spinal onset. Sometimes start with the tongue and the slurred speech. We call that bulbar onset. Sometimes it's only lower motor neurons, and we call that primary muscle atrophy. Or it can be only upper motor neurons, which is primary lateral sclerosis. But it sort of begins to be a spectrum from here to here and in between. There's a couple of diagnostic criteria, which have many years now, started in 94 and then revised in 2000 and recently another one. The more elegant you want to be, the less sensitive it is. The so-called ALS criteria is like 50%. You mess most of them. When you find it 2 years later, then it's very obvious. So they reduce that and put electromyogram, and they say, okay, we can diagnose more. And now they just drop it and says, if you have upper and lower in one region, or if you have two lower in two different regions and you rule out everything else and it's progressive, that's likely to be. So the sensitivity went up. And we're looking for better than that. I'll tell you more in a second. Here, the same, there's other subtypes. Like it looks like it can be like a neuropathy, so more distal in the extremities. It can be like a stroke, so half of it hemiplegic, or it can be just in the arm, which is very, very incapacitating, or it can be only in one leg. So there's different phenotypes. And what they show here, Dr. Al-Chalabi in England has looked at, okay, what is the progression the same on these different phenotypes? And it's somewhat it is, they're all progressive, but some of them are a little bit faster than others. So the progression changes, so kind of different progression there. The other thing is this data set. It's called the PROACT. At some point, there were like, I don't know, over 10 large studies, and they were all grouped. And then we studied the progression of them. And what they saw, this lead by Dr. Bedlack in Duke, he shows that 25% of the patients, sometimes they don't change anything with 6 months. So you measure things, they are progressing, they have a plateau for 6 months. And that is 25% of the patients. 16 may not change for a year. And a small percent, 6.5, over 18 months. So even though it's a progressive condition, in its own, it might just, okay, I'm gonna quiet down for a while and I'm not progressing. And that is really tough for clinical trials, because you might have in a 6 months trial, that's what we have now, at 25%, they are not gonna change because they don't. And why? We wish we knew, but it's not so linear that you can predict all of it, but some 25% will plateau. So that's why that statement that a small study in phase 2, or if it's open label, and you have, oh, I got a bunch of patients and didn't get worse. I said, well, 25% down, so don't anticipate. You have to go for a phase 3 trial with 500-600 patients to actually see whether that works or not. And we have an example that we have a phase 2 called Relivrio. It got approved by the government, and now we have a phase 3 comes out of Europe with 660 patients. It says it doesn't work. So now the company is pulling one of the 4 medications we had, and so we're back to 3. How am I doing, Dr. Tabor? On time? Okay. This is a very colorful. It has to be done by a speech therapist. This slide. It was one of the mentors, Dr. Plowman, a long time ago. It's beautiful. But here it tells you, the upper motor neuron, the lower neuron, and inside of the features of the two. But again, this to tell you there's all these symptoms can be confusing because there's different subtypes, there's genetics, there's different disorders within, and it's very, very challenging to make the diagnosis. Malnutrition, psychosocial, cognitive. The other thing here is, what do they die from? So it's respiratory insufficiency, particularly the diaphragm, and they only using the accessory muscles. We do manage them with non-invasive ventilators, and a percentage of them we call tracheostomies. And our work is to keep them at home. And that is thanks to the work of Lauren, but particularly we have respiratory therapists, and Gaby Lopez, the nurse practitioner, she comes right from the ICU with a lot of expertise in ventilator management. So we have to handle, you've probably seen they come with ventilators in these power chairs. Malnutrition, many of them do lose weight, not only because they can swallow, but also some of them swallow just fine. But some of the connection to the hypothalamus take the appetite away, and the effort, so on and so forth. So there's a lot of has to do with malnutrition, and we have to have a nutritionist. Andrea Chavez is doing an amazing work trying to figure out how to have nutrition with high density, high calories to make sure that they don't lose weight, because it's one of the predictors of faster progression. Now, the psychosocial impact, and Dr. Tabor has been interested, and I've been interested even from other disorders when I did epilepsy, is what are the factors that really have this impact? And I tell all the patients, they don't get ALS, the entire family does. The patient definitely is at the core, but I can tell you the stress and the suffering, the financials, and all the other things that this causes in the families is just unbelievable. I cannot tell you, even super rich people have a lot of problem with this. Doesn't matter. It doesn't matter. The wife of Phil Smith, before she got so stressed out about this, it doesn't matter the money you have, you still go through a lot of burnout with this. Now, 30% of them may have dementias. And one of the genes that we have now is called the C9 open reading frame 72, which is also another confusing disorder for me because this gene can cause different things. Is the most common cause associated with both dementia and ALS. If you want to have something bad, you can have both. And it's a nightmare to work with this. It is not the same as Alzheimer's. It's a frontotemporal dementia. It's behavioral and executive functions. They remember and they look okay, but they have all kinds of different abnormalities. And again, this gene, which is the most common of the genetic disorder, is the one associated with this. But others, even with C9 negative, they can have also frontal dementias. And 30% is appropriate when you're trying to look at kind of the initiation. But if somebody makes it to the 5 years and you do trying to examine all other cognitive functions, the association with the frontal lobe will have some deficit. And probably some people say at least half of them will have some cognitive issues, if not clearly clear to the dementia level, but they do have issues following that. And then the loss of independence, I can tell you, the bibrachial weakness, they are walking, they're talking, but they cannot clean themselves because they cannot, they're not independent. They're fully awake, they're sharp and everything, but they cannot clean themselves. So just to tell you how strong and problematic this is, how frustrating it is not to be able to say what you want or what bothers you. Your communication gets impaired, and you're smart, and you can just get it out. So we have a whole program for communication. Lauren has all kinds of equipment. We call it from a very low tech to a very high tech. And we most of the time use even combinations, writing something, a board, phone apps, text to speech, or then the full-fledged with eye movements, because the eye muscles for eye movements is probably the last one to go. They do go and they get locked in at the very end, but usually they can maintain eye movement. And with that, we can keep a window open to be able to communicate with them. And the motor skills, they cannot feed themselves, they cannot walk, and they need different devices to be held, to be fed, to cut, so on and so forth. So here is what we do, and this is the main trial. It's a Healy platform trial. It has now 7 regimens. The first 4 were completing. C and D had some positive impact, and I'll tell you a couple about that. Regimen E was an intravenous infusion. It did not work. F and G, they just completed enrollment. We're going to have results out of that by the end of the year. The study is a platform, meaning it keeps repeating itself, so we add and remove arms. So there's a master protocol, then you randomize to one of them, and then we share the placebos. So it's a 3-to-1 randomization. So only 25% of the patient get placebo, everybody else get drug. And at the 6 months period, they all get drug. So it's very beneficial in that regard. 6 months is questionable whether you can talk about efficacy. So this particularly is more of a phase 2 study, kind of a smaller number, and trying to see the go, no go to a phase 3 that will enroll maybe 500 patients. So no, so you do the screening and you qualify. And then we randomize you to one of the 4 regimens. And then you keep going, you randomize and you go. And then when you finish the 6 months, you go to active treatment. And then what happens is you need to wait for the last patient to finish the 6 months. So if you enroll at the beginning, you finish your 6 months earlier. So you'll be waiting on medication until right. It's a great design. It's borrowed out of the oncology group. And again, we have 7 drugs. Now we're going to revise the master protocol. And then towards the end of the year, we're going to bring another 3 regimens to it. Right. So they will be happy to talk to anybody. This is out of Mount General Hospital. This was, is a great platform. And I want to say that there's 80 sites in the country, and we were #1 at Holy Cross. we came back, and now we're head to head with Mass General #1 in the volume of recruitment. So we are really kicking everybody's butt about the volume, despite being new and everything else. And you probably can't tell that I'm proud of this, but I am, because it opens a whole set of opportunities. So these are the drugs. I'm going to speed up but they have different mechanisms. The last two from Clene and Prilenia, they both had positive results. Didn't make the primary endpoints, but they do have some positives. So what happened is the companies move into have open EAP, so expansion, early access programs, or expanded access programs, or EAPs. And essentially, Clene is a purified water, very, very pure water, and then put some wires, and they make nanocrystals of gold. So this is really super pure water with nanocrystals of gold in the billions per part. So this goes to the membranes, particularly mitochondria, and allows the cell to have more energy to fight the disorder. So it's an energy enhancer, if you will. It has been treated also in Parkinson's. And so totally is like 500 patients plus, and pretty much there's zero side effect, because this is actually water with nanocrystals. And actually they have pretty good in both. They think they're going to move forward with both. So this is actually more of a global treatment. I think that at some point when I walk on down the supermarket alley, when I grab one of this, and I'll take it. Prilenia is actually a very interesting molecule. It's an alpha agonist, sigma-1 agonist, and it seems to be working on the brainstem. There's another medication for symptom treatment called Nuedexta, and Lauren has really done an amazing study that showed not only work for what is suitable for affect, but actually have improved speech and swallowing features. So she predicted, when she saw the mechanism of action, and told us that thing is going to help speech and swallow. And actually, when the study finished, it didn't make the primary endpoint, but actually helped speech and swallow. And we're very happy because we have expanded access program in both of them. We got about session in 2 weeks. This one, we've been doing it. This is expanded now. The government put millions of dollars for it. But that one now, we have the expanded access program. We're trying to tag along and trying to study not only be an expanded program, but also trying to study speech and swallow in these patients that we're going to enroll. So this came out of, in 2021, 100 million a year worth. So it's 400 million that the government put for research, and they have been throwing a lot of this money in these expanded access programs. So there's few sites. There's like, 5 to 10 sites maybe in this thing. So this is one of the things that is great about these programs. Patients, for the randomization, they had to be early in the disease. They had to have good vital capacity, so breathing has to be okay. But many of them passed those numbers, and they say, well, I want to participate in research. I said, no, you're excluded. You don't meet criteria. And they get upset. So they went up to the government and says, we want options. So these was created and passed as a law. It's called the expanded access programs. The pharmaceutical company would put the medication for free, and the doctor is supposed to volunteer their time and potentially give the medication. That grew into be more organized. So the government now is paying for it. So we can, it's not the super, super great pay, but they're okay. They pay, and then we can give patients that do not qualify for the platform trial or any of the other trials. They are past that phase, but we can give this medication. So there's no placebo. So they all had to have it. We follow safety, and it's a little bit less measurements. So we don't burden them with, pull, push, and let's draw blood, and let's do a million things. So it's super nice on the patients. They all get the medication, and many of them are looking forward to have them. And I'm going to stop right there. The one thing, if you give me another 20 seconds, is this. I've been looking into how we're really going to make the diagnosis. We're going to have probably the training on the skin test for synuclein, which is for Parkinson's. So Alzheimer's had a problem. We failed the study for decades. Billions of dollars were used. NIH went back and redefined the diagnosis and says, okay, if you have amyloid and tau, and we showed that you have some neurodegeneration, but particularly if you're amyloid positive, tau positive, you have Alzheimer's. It didn't say whether you're forgetful, whether you got dementia or MCI. You have Alzheimer's disease because you had the pathology. And we know that it starts a decade or more before you have symptoms. And they've been working on that. They're even refining them because now they realize there's mixed pathology. They may have tau proteins too. They may have TDP-43 pathology in some of them with, they may have C-nucleate, proteins. So they have kind of Parkinson-like dementias type of thing. So they have this ATN, amyloid and neurodegeneration with an X there because there's mixed pathology. In Parkinson, they come back with the same because, we knew for a long time that people with Parkinson's smell differently. They look differently. The skin got something. We kind of knew it for a long time. But now, biopsy, boom, loaded on alpha-synuclein on the skin. So it's pretty much over 95% sensitivity to tell if you have Parkinson. And you can know that at the very beginning with the little tremor. So they do have also, synuclein neurodegeneration. If you have imaging with PET or, DAT scans, that you can, okay, you have synuclein, you have a DAT scan, you're great. And then they test your genes because about maybe 15% or so people may have a genetic form of Parkinson. The genetic end up being negative for synuclein, but they have also an algorithm to diagnose Parkinson's with minimal or risk factors. So you want to diagnose it very early. It has to come to ALS too. The TDP-43 pathology, which is kind of the hallmark, is seen in muscles, is seen in some skin. So I'm working with this company, Sing1, to see if we can have some sort of special stain, because it will be really nice that if we have a skin biopsy and trying to make that diagnosis earlier, and the more certain that that's what it is, or we don't have a mixed pathology. So looking from these markers, whether it's spinal fluid, blood, or particularly skin biopsies, are going to be the way we're going to transform the diagnosis. And hopefully that will give us a much better idea on what we have in front and how we select the population. Hopefully, the frustration we have with all the studies will come that we define the population better and the outcomes will be a little bit better. And with that, thank you very much. All yours. And then took about 6 minutes of that. Oh, you won everything.
Okay. Thank you. All right. So now we're going to switch over to talking about some of our investigator-initiated funded studies. In lieu of time, I'm just going to, yeah? Not if my slides don't work. It's the down arrow, enter. There we go. Okay. So the focus of the investigator-initiated programs that I'm going to talk about today is a recently funded Department of Defense grant looking at combined respiratory strength training to improve pulmonary and cough function in patients with ALS. So Dr. Locatelli just very nicely outlined kind of the hallmark features of the disease, with the leading cause of death being respiratory insufficiency. So this is a very important therapeutic target for us. And I'm kind of going to go through the story of how we got to this combined training regimen and the theoretical framework of how the idea of an early intervention respiratory program can improve breathing and potentially airway clearance capacity in this population. So kind of going from very big picture, we're going to hone in on one single study, kind of one of the things that we're focusing on in the clinic. So a little bit more about the disease from a bulbar standpoint. In this patient population, dysphagia, which is swallowing impairment, and dystusia co-occur and occur in the vast majority of patients with ALS. So here we have one of the studies that we do, which is a video fluoroscopy. So we have a patient seated in the lateral viewing plane. They're being given a barium contrast, which is the black material that you see them swallowing. This is a thin liquid bolus. And one thing that you'll observe here is as the bolus enters the food pipe, which is here, the esophagus, it also enters the airway. You note that the individual demonstrates a cough response or a throat clear because the material comes back up through the vocal cords. But one hallmark feature of this is the respiratory insufficiency leads to an inability to clear the throat. This pertains to eating and drinking, so when you're drinking liquids, but also to managing secretions and clearing the airway, particularly in the event of an upper respiratory infection. The current management of these symptoms in ALS is relatively palliative in nature, meaning that we talk about feeding tube placement very early to try to mitigate the weight loss that we know to occur, and also provide an alternative means of nutrition while these patients are going through this progressive dysphagia. We can modify the diet to things that are more soft and easier to manipulate, cutting down on energy expenditure and increasing their ability to intake more calories throughout the day. We have some somewhat effective compensatory swallowing strategies, mechanical respiratory support. So this is in the form of non-invasive ventilation, and also a machine that helps improve the effectiveness of their cough. These are unfortunately really guided by the insurance parameters that we're forced to adhere to with our patients. So they typically have to develop a significant amount of respiratory insufficiency before we can implement these therapies. It's MIE, so it's mechanical insufflation exsufflation, and the devices can be really effective, but unfortunately they're often used when the patients are already very sick. So one of the things that we're trying to focus on, and much more recently in 2023, we came out with some new, the American Academy of Neurology came out with some new guidelines to focus on more proactive management, given that these patients are known to decline very, very quickly. So the practice parameter specifically stated in terms of screening for malnutrition and dysphagia that we want to address symptoms earlier so that we can provide these interventions, and which potentially can lead to prolonged survival and improved quality of life. So that gave us a lot of credibility when it came to intervening earlier with these respiratory interventions. One reason this is a little bit of a problem in this particular disease is because historically exercise in general was contraindicated. It was thought to hasten the progression of the disease. There are a lot of basic science studies and animal models that looked at high intensity treadmill training and found that the motor neurons died more quickly. And a few studies decades ago laid a very poor foundation for using exercise in ALS. Not until more recently, in several systematic reviews, we found that mild to moderate intensity exercise, so again, very important looking at dose, was shown to have beneficial impact on motor function and survival when applied early in the disease. So the theoretical framework being, can we harness the remaining plasticity to try to mitigate the decline of these crucial bulbar functions and improve their respiratory capacity? So the premise for this grant is looking at early respiratory training to maintain function. So again, nothing curative, strictly looking at symptom management and potential improvement. The therapeutic targets are to strengthen the function of cough, which potentially can improve the ability to clear the airway, not only during meal times, but also when patients are sick or have increased secretions, which our patients often do. Sialorrhea is a primary complaint. So you can see here that a typical ALS disease decline, as we all know, is not linear, but relatively steep in nature. And the idea behind this training is to mitigate that. So first, about 10 years ago, strictly looking at expiratory muscle strength training. So this is one respiratory trainer that you see here. The exercise consists of forceful expirations to quote unquote break the seal. So kind of looking at the device here, we have a mouthpiece. Within this device, there's a spring-loaded valve. So a certain amount of resistance has to be placed upon the valve in order for the seal to break. So short ballistic movements, kind of like doing repetitions at the gym of a bicep curl. It's very similar, only for the respiratory muscles. Same training premise with exercise physiology. We looked at progressively increasing the resistance load based on each individual's maximum expiratory values. So the training is customized to each participant. And the regimen includes a daily training, 5 sets of 5 repetitions. So that's 25 repetitions a day, 5 days a week. So when we first looked at this, we found when we characterize improvements in swallowing and airway clearance, we look at swallowing efficiency as well as swallowing safety and clearance. And when we looked at the physiology behind expiratory muscle strength training, we found using fine wire EMG, our group and others, that we're activating a lot of muscles involved in upper airway defense, including the submental muscles, velopharynx, pharynx, and highway displacement. But we're also impacting a lot of the muscles important for expiratory function or respiratory muscles. And these included the subglottic muscles, so muscles surrounding the vocal cords, and improved peak cough flow and cough volume acceleration, which are surrogate measurements of airway clearance. First, when we looked at expiratory muscle strength training alone, we found, so here we have the study design is, this person was part of a larger trial, but this is an individual kind of super responder to the therapy. We let in with an 8-week sham training protocol. So that was the device that we used minus the spring valve. So they're blowing across atmospheric pressure. We did that training for 8 weeks. You see that there's no improvement across the 8 weeks. We then introduced the EMST device, calculated to 50% of their maximum expiratory pressure. And we found 102% improvement over the following 8-week training, as well as a 3-point improvement in the ALS-FRS, which is our gold standard scale for disease progression. We also found, important for the current study, improvements in cough-inspired volume and voluntary cough total. So overall, a lot of improvements in subglottic pressure generation. The 3 metrics that you see in blue here are really important for expiratory function, so clearing the airway. When we looked more closely at the ability to draw air in, we found no improvement. So we found that this therapy, as predicted, would impact the ability of the expiratory muscles, or the expiratory muscles involved in respiration and breathing, but no impact on inspiratory function. So that led us to think, what can we do to target both? So we kind of went backwards a little bit and characterized cough in individuals with ALS. I'll spend a little bit of time on this slide because it's the primary outcome measure for our current study. So here we have a cough waveform. This is a healthy person. So we have airflow followed by time. And here we see a very distinct inspiratory phase, a very distinct compression phase, which is indicative of the vocal cords coming together to build that subglottic pressure to clear the airway, which we see very distinctly here. And when we characterize this in individuals with ALS, so we have a spinal onset patient, which if we recall is the patients that arms and legs are affected first, bulbar musculature is preserved for a certain period of time. We see a somewhat reduced inspiratory phase volume and a prolonged duration, an absence of a compression phase, and therefore a reduced peak expiratory phase. And this is even more profound in a patient with bulbar involvement, in which we see almost no inspiratory phase. It's very long, very shallow, no compression phase, and a subsequent very weak peak expiratory flow. So this led us to believe that, not surprisingly, we need to target both inspiratory volume and inspiratory duration in order to have an impact on cough function. So this kind of laid the groundwork as to why we wanted to target both inspiratory and expiratory function in our patients. And one way that we can do that, you may be familiar with the lung volume recruitment. So this is more commonly known as breath stacking. This is a prophylactic routine to maintain chest wall and lung compliance. It's been studied in a lot of patient populations, in hospital, post-surgical, and in neurodegenerative disease in Australia alone. There's been a single randomized control trial of LVR. This was Dr. Shears, who is a consultant on the current grant, out of the University of Melbourne, Australia. And they found that the training was safe and feasible and also led to increased insufflation capacity, which is one of the primary outcomes that we look for disease progression in ALS. So here we have a short video of lung volume recruitment alone. So you'll notice the patient or volunteer has nose clips on. Dr. Shears is successfully squeezing the ambu bag. The patient is stacking their breaths without breathing out, and then breathes out after the training is over. Yeah, very rare, but you can puncture the lung. There could be a trauma or a pneumothorax. It's not been reported in any of the studies with ALS patients, and it occurs in less than 1% of the time with lung volume recruitment in general. Supervision with the task and extensive training is really important to make sure that you're reducing those risks as much as possible. So the current training that we're using in this study involves combined lung volume recruitment and expiratory muscle strength training. So to give you an idea of what occurs, these two pieces are actually attached with a T-piece. And what that means is the patient's going to recruit with the mouthpiece in. The EMST device will be set to 50% of their maximum pressure, and they blow out directly into the device. And they'll do that 5 sets of 5 repetitions for 25 repetitions a day. Yep. So I'll go over the study design too. So back to our theoretical framework here, we're intervening early with this prophylactic LVR and EMST treatment with the idea to delay the need for cough assist and non-invasive mechanical ventilation. Prior to submitting the grant, we did 2 pilot patients looking at peak cough flow and forced vital capacity, which are 2 primary outcomes of disease progression and that lead to respiratory insufficiency. So here we have at baseline 360 and 460, and following 12 weeks of combined LVR and EMST, it led to a 40 centimeter per or liters per minute improvement in peak cough flow in patient 1 and a 20 liters per minute improvement in patient 2. While this might not seem like a very large improvement, this particular measurement is anticipated to decline about 15 liters per minute a month in this population. So over the course of 12 weeks, for us to see any sort of improvement and not a decline is a more significant treatment effect than this graph leads you to believe. Similarly, looking at forced vital capacity, we see a 4% improvement and a 4% improvement in both patients following 12 weeks of training. And again, this measurement is anticipated to decline about 2.5% per month in this population. So for that to improve over the course of 12 weeks is also significant. The primary aims of this study are to determine the impact of this training on cough strength and respiratory function, not surprisingly, but we also really wanted to focus on feasibility and adherence to therapy. These patients have a lot of things on their plate when it comes to improving and managing their disease, and adding one more thing might not be feasible. So our secondary outcome is to look at not only patient-reported shortness of breath, but training compliance and adherence to get some feedback on that. So the study design is depicted here. It's 3 in-person visits. We tried to reduce the burden of the patient to travel to clinic as much as possible, which is why we incorporated a lot of telehealth. The first visit occurs baseline 1. We do a full bulbar assessment, including a fiber optic endoscopic evaluation of swallowing, which gives us a look at the vocal cords, looks at the integrity of the anatomy and structures. The patient goes home for 5 weeks in which they do nothing, so a 5-week interventionless lead-in period. They come back for their second baseline appointment, at which time we'd repeat the same measurements. That's when they commence the LVR and EMST training. And they go home for 5 weeks and they do the training, 25 repetitions a day, 5 days a week. Home therapist follows up weekly with them and does the measurements that are depicted here. They come back at visit 3 and they repeat all the same measurements again. So again, trying to cut down on the burden of the patient visiting clinic as much as possible. And after they're finished the study during months 1 through 6, not only do they come to clinic and see us so we can repeat the same measurements during standard of care, but they're followed up monthly to look at if they're continuing the training and to take some measurements of respiratory capacity at home. Our primary outcome is looking at peak cough flow, which is a measurement that you're somewhat familiar with at this point. And we're looking at it 2 ways. One, we're using a cough spirometry, which is this waveform that you see below. So we can depict looking at timing and kinematics of these airflow parameters to see if they change from baseline to the first period, in which we would anticipate a slight decline, and then from the start of the therapy to the end of the 5 weeks. This was one way to cut down on the sample size needed, given the budget that we had, and also to look at offering the therapy to all patients without the need for a placebo. So each participant is kind of acting as their own control. We're comparing the measurements from baseline 2 and final to baseline 1 and baseline 2. And then we also use an endoscopy. So that's something where I place a camera down the patient's nose, kind of take a bird's eye view down onto the throat. And while they do the cough spirometry, I'm able to look at the vocal cord kinematics. So the opening, the closing, the compression phase, these are time synced. So we're able to see at which point the events are occurring and if it's inappropriate compared to the normative data that we have. Of course, we also have some secondary and tertiary outcome measures, which are listed here. We're looking at a lot of pulmonary function testing, maximum expiratory and inspiratory pressures. Everything that you see here in the gray box gives us a lot of information about how a patient is progressing across their disease. Forced vital capacity is something that we use as kind of a surrogate of life expectancy. You know, if that's progressing very quickly, it's not a good sign, and it's something, obviously, breathing, very important. It gives us a lot of information about the way that the disease is going. In the blue box there, you see we're looking at a lot of global disease progression and quality of life. This is primarily patient-reported outcomes and some feedback that we get from the caregivers during the assessment. So our current enrollment, we've enrolled 9 out of 40 participants. This study runs through 2026, so we are well on our way to completing it as we wanted. Importantly, we've had no training-related adverse events, and adherence to therapy during the active treatment phase has been greater than 90%. So we're very happy about that. Results to follow, so stay tuned. Maybe we'll come back a year from now and have some really exciting preliminary data. But thank you very much for your time and for the invitation to hear our work.